there. My name is Rachel Greene. I am a postdoctoral fellow at Oregon Health and Science University. Today, I'm going to be talking about a paper that I co-authored with some of my colleagues here in the Clinical Neuropsychologist. And the paper was really looking at the ADOS-2 and elevations on the ADOS-2 for children who do not have autism. So looking at who those false positive cases were. And so, as many of you know, the prevalence of autism in the US has increased year by year. Current estimates say that it's the prevalence rate is 1 in 59 children. And with that increased awareness of ASD, there's also increased demand for ASD diagnostic evaluations. And so at our clinic alone, here at OHSU, we saw approximately 600 plus folks for ASD evaluation between March 2019 and March 2020. Certainly things changed after that point for almost everyone. And I'll talk about that a little bit, but a lot of this research was conducted prior to COVID. And then within that group of individuals, it was a quite complex group in terms of developmental and psychiatric presentations. And so 56% of those children, adolescents, met criteria for 2 or more psychiatric diagnoses. And so we thought this was really important to explore a little bit more and really how the ADOS does at differentiating folks within a psychiatrically complex sample. And so, you know, again, as many of you know, there are a variety of differential diagnoses that or possibly co-occurring conditions that we can see alongside autism. And some of those are developmental in nature, some are psychiatric, some are medical. Many people have a variety of these. And so parsing apart what the core criteria and core features of autism are versus some of these other diagnoses and presentations that can be challenging. And so again, like I mentioned before, we really wanted to look at the ADOS-2, the Autism Diagnostic Observation Schedule, because at that point, and even still, it is the most widely used and prominent measure for observational assessment of autism spectrum disorder features. And essentially, this is a semi-structured play and or conversational interaction between the examiner and the patient. In younger modules, the parent is also present. And then it's scored really to assess the presence and prominence of core ASD features in both the social domains and restricted and repetitive behavior domains. So those kind of classic symptoms of autism. And then the ADOS also includes, you know, other behavior codes to assess for things like overactivity, tantrums, or negative behaviors and anxiety, to really better understand if that's playing a role in the presentation of the individual during that observation. So we'll get to that in a little bit as well. And, you know, by and large, the ADOS has quite good psychometrics. It's highly specific and sensitive when compared to children who are neurotypical. So comparing neurotypical folks from those with autism, it does a good job of categorizing those and really differentiating those groups based on the algorithms that are provided and things like that. What we do see though is that when there is greater psychiatric complexity or other disabilities, you know, communication challenges, intellectual delays, that's a little bit more challenging and there's a little bit more overlap. And so we see this kind of false positive side of things kind of inching over So folks who are meeting diagnostic criteria on ADOS, that, in this case, we'll talk about that autism spectrum cutoff of the algorithm, and they're meeting that, but they don't go on to meet formal diagnostic criteria of autism for whatever reason. And, we feel like this is really important because having an accurate diagnosis is associated with reduced engagement in and improved outcomes following psychological intervention. So in other words, receiving a false diagnosis, an inaccurate diagnosis, can really alter the treatment course and trajectory for folks, potentially leading them down into treating something that is inappropriate or inaccurate. And so the current study really wanted to look at this in more detail with our kind of clinical sample. Again, this is clinically referred folks coming into the autism diagnostic clinic. And again, this is that same figure that I showed before. And I want to highlight that we're looking at this group. So now this group that is here in green is false positive on the side of that bell curve, who again meet criteria for ASD on the ADOS cutoff, but do not go on to have autism. And in this sample, and this question really arose because 34% of folks who received, in particular, the module 3, 34% of them had false positives. So they were meeting that criteria but did not go on to have autism. So that's a high number, and I think really reflects the complexity of the sample that we're seeing clinically. And so just in terms of demographics, we wanted to explore, are there things that are differentiating these groups in terms of basic demographics here? And I will say that race variable there, it's a high number of white Caucasian patients, and it is reflective of the geographic region in which this research was conducted, though it is a limitation of this study for sure. But I'll kind of highlight the things here that came out just in these initial t-tests and chi-square tests that differentiated the true positives from the false positives. And in particular, gender identity trended towards significance such that female patients were much more likely to receive an ASD diagnosis if they met the ADOS-2 criteria and cutoff. So much more so than their male peers who may also have been elevated on the ADOS, but did not go on to receive the diagnosis. So if a female was elevated on the ADOS, more likely than not, they were to receive the ASD diagnosis. And then additionally, the ADOS-2 RRB severity score, that calibrated severity score, was significantly predictive of group membership as well. False positives tended to have lower RRB scores than true positives. That was not the case for that social affect calibrated severity score. We saw similar levels of kind of social affective differences for true and false positive during the ADOS observation. And that's just based on these initial, again, t-tests and chi-squares. We then did a logistic regression to really look at all of this in one model, kind of controlling for one another. And we found the following to be significant. So in this case, when you're looking at all of this in one model together, controlling for one another, we see that both the social affective and the restrictive repetitive behavior severity scores were significantly differentiated group membership. And then we also saw that the anxiety behavior code on the ADOS was also something that differentiated groups. And so we wanted to explore that a little bit more. And so we did some chi-square analyses looking at different diagnoses that folks left their visit with. And so in this case, we see ADHD, anxiety, and then we kind of pulled out trauma-related disorders. And so things like, unspecified trauma or stressor-related disorder, PTSD kind of fall in that category, whereas anxiety included the other anxiety disorders, not including PTSD. And we found that folks with those trauma-related disorders were more likely to fall in that false positive group who did not go on to receive the diagnosis of ASD. Rather, the symptoms and features they were presenting with were better attributed to their traumatic experiences. We saw that same relationship to some degree, though not clinically significant, with broader anxiety disorders, like generalized anxiety, social anxiety, OCD are included in this. And again, kind of trended towards significance. And we did not find any significant relationship between individuals in the false positive and true positive group who had ADHD. Those appeared to be relatively similar. And so in summary, we found the following were associated with false positive results. So false positive were more likely to be male. So again, those female patients that we saw were more likely to go on to receive the ASD diagnosis if they had an elevated ADAS-2 score. We also saw that heightened anxiety during the ADAS-2 was associated with false positives. And then reduced restrictive repetitive behavior and social affect severity scores on the ADAS-2 were associated with false positives. So those kind of core features were slightly lower in the individuals that were false positives. Again, they met that kind of ASD cutoff, but those scores were relatively lower. And then false positives also showed increased rates of psychiatric diagnoses such as trauma-related disorders, and then that anxiety disorders trended in that same direction, but was not clinically significant. And then, the conclusions and really takeaways from this, it really just highlights the importance of interviewing around a variety of things, but anxiety and restrictive repetitive behaviors in particular to differentiate folks who may show a number of ASD-like features and symptoms, because those pieces can really mimic what we think of as classic presentations of autism. And, like the creators of this measure highly suggest and encourage, the ADAS should not be used in isolation. It should be used to inform a full diagnostic battery, including interviewing, gathering behavior observations, looking at cognitive and communication abilities, talking with other people like teachers, and getting that really well-rounded understanding of that individual's functioning across a variety of contexts. And this is kind of one piece of that puzzle, very important piece. It's nice to have that standardized measure, but it plays kind of one piece of that evaluation, and should be considered pretty cautiously when working with folks in clinical or research settings who have high psychiatric comorbidity or other developmental differences. And so next steps for this would kind of looking at things in the future would be to consider for clinical settings, consider treatment for anxiety while on ASD diagnostic clinical wait list. And so encouraging folks to seek out that treatment ahead of time. Those wait lists are often long. And so not only is it providing families support in the meantime, but it could also make that diagnostic picture a little bit clearer when they do get to that visit. And then, future research could really focus on how to identify symptoms of trauma-related disorders and anxiety and how they overlap with core ASD symptoms, because there does appear to be that overlap there. And that's kind of muddling the diagnostic picture to some degree. And so that would be important for us to really understand a little bit better. I want to say thank you to all of my colleagues at OHSU. Dr. Susanne Duvall was my mentor on this project and a co-author. Appreciative for her support, and others. Thank you so much for listening.